Good day, everyone. It's me, Prathalan, a clinical psychologist and interpersonal therapist. We have been having our regular program that is the clinical course of treatment management in psychopathology. Today, we are going to have a lecture on bipolar disorders. Whenever we are talking about the bipolar disorders, being a professional, we all know that we have to go through the DSM, that is the Diagnostic and Statistical Manual uh, in case of diagnosing the psychological disorders. So yes, we have a very huge domain to cover in case of bipolar disorders and its relevant disorders as well. That includes the bipolar 1 disorder and then bipolar 2, cyclothymic disorder, substance or medication induced bipolar disorder, then bipolar and related disorder due to any kind of medical condition, other unspecified or specified bipolar disorders. So, when we have to talk about any kind of disorder, we personally, being a professional, I suggest that we should first go from the history, right? So, in the previous version of the DSM-5, mood disorders have been divided into two different chapters. The first one was for the bipolar and related disorder, and the other one was significantly about the depressive disorders. All right. But later on, it was suggested that the term mood disorder is more appropriate than the affect itself. Previously, the word affect was more commonly used for the fluctuating moods or the emotional changes or the emotional expressions. But then it was perceived as more sustainable and pervasive about expressing the feelings or talking about the emotions. So now we have been suggested to use the word mood for that. Right. So in case of um, DSM-5 TR now, obviously bipolar disorders have a very huge chapter to be covered. And actually, that whole lengthy chapter have a lot of specifiers to be confined of. So, for example, those all the specifiers allow us, being a clinicians, to record whether the condition is recent episodic or just a current episode only, or the client is manic or hypomanic or just having a depressed episode right now. The nature of the episode can be determined easily now. Right. So now, we have a very much differential diagnosis that is a bit complicated till now as well. But if we have to talk about the bipolar disorders and the related conditions, um, if I have to express my concern, I would be suggesting that the bipolar or even the entire DSM-5 GR now have been very much less complicated and you can say a very much research based. That is a very good thing, right? We have a clear cut indication about the nature of the episode. We are very well aware about the comorbid factors associated with that kind of episode to be dealt with, right? We know if either it's anxious distress, if a client or the patient is having just the leaner manic episode. So yes, it's a very much admissible now. All right. So when we are talking about depressive and the bipolar conditions, they were basically very much similar in case of DSM-1 or DSM-2 or DSM-3, but those all were considered as to be, kind of like having the, okay, all right. So now we have a very much classified information about the psychosis, all right, and the mood syndromes as well, by predicting their stressful life experience, encoding the DSM, right? So, previously, unipolar and bipolar disorders were very much separable in case of diagnosis, but now they are being considered as a very much complex force and outcomes to be related to, right? So here is a basic display for the diagnostic and statistical manual of disorders. So this whole chapter will include these particular conditions to be discussed about. We will overview the whole monoculum. The first one is in the DSM-5, relatively, bipolar disorders were placed between the chapters for the schizophrenia spectrum disorder and other psychotic disorders or the depressive disorders, right? It was primarily written before the depressive disorders, right? So it was because this disorder has a very much bridging state between the schizophrenia or the psychotic episodes and the depressive episodes because it can have a morbidity to display in case of one patient, right? Because a patient can have a manic episode, then along with the delusions, he can have a very much significant kind of psychotic display as well in case of depressive episode, right? So it was placed in bridge between these two kind of different disorders. So they were having a very much huge change recently in the DSM with the goal of improving the specificity and sensitivity of the diagnosis. So yes, it was basically to reduce the delay from the onset of the first symptom to correct the prognosis and the diagnosis as well uh, because of misdiagnosis, people with a bipolar disorder often have received a very much inappropriate treatment, such as the antidepressants and a very much insensitive psychopharmacotherapy, right? So previously, basically, the patients with the bipolar disorder, due to being misdiagnosed, they were having a treatment with the lack of mood stabilizers. So that had put them with a lot of risk at the cycle acceleration, or you can say, actually place them in that particular vicious cycle they were going through. All right. So the current state of the diagnosis, and you can say the change in the DSM-5 TR have actually improved the diagnostic precision for diagnosing the DSM regarding disorders and the mood disorders and all that stuff, right? So whenever we are talking about the mood disorders work group, was added as a phrase. All right. For particular books, you would study there that there is a term being used that is the persistently increased goal-oriented activity or energy. That is basically, you can say, the phrase that are being defined for the mood disorders. All right. So yes, in case of mania or hypomania, this is a particular phrase to be used, right? The patient or the client having a mood disorder, especially having a manic or hypomanic episode, can have a very much persistent increased goal directed activity or behavior. And he would just have a lot of energy to work on and they won't feel get tired, right? So there are a lot of diagnostic specifiers. Now, moving toward the disorders, first of all, you have to understand what is mania or manic episode. So these are the contrary terms being used in the bipolar disorders. And first of all, we have to understand them very well, right? So in case of diagnosing the bipolar disorder, the mania or the manic episode actually means the following condition. All right. The first thing is, as we have discussed about the phrase, that is the distinct period of abnormally and persistingly elevated, expansive, irritable mood. Or I can say in a very similar words or very, you can say a layman words, that it actually means a person is having a very much consistent pattern, or you can say a form of energy, having an irritable mood, and have a lot of activity going on that lasts almost at least a week or present most of the day or nearly every day, right? If a person is actually having a very much irritable mood and having a, expansive sort of mood, elevated and, the kind of abnormal mood going on, and he's having a very much increased feeling for the energy, or you can say the activity going on, and you can think like that person is having something going on that's not himself or herself right now. So at that moment, if you think the hospitalization is now necessary, you should go on, because it can be the onset for the manic episode. All right. So in case of manic episode itself, the duration of the mood disturbance, or the energy or the activity going on, can be three of the following symptoms most. So the degree of the significant change, or you can say the mood issue, can be having around noticeable change from the usual behavior, can be like in the following domains: having inflated self-esteem, or you can say the grandiosity, like I'm some kind of like God, all right, or I can do whatever I want, all right. A patient can actually tell you a lot of stories about being a CSS aspirant, or I'm the prime minister of my country, and all that thing. That is the grandiosity, all right, and that can sometimes be a delusion. So you have to be very well aware of the client's history first, all right. So then comes the decreased need for the sleep, all right. If a patient is reporting having a very much decreased need for the sleep, or you can say the patient is actually not sleeping very well, right? From the last almost a week, you or the family is perceiving like the patient is not actually very well forward toward sleeping good, all right? And he's being more talkative than usual, all right? Or you can say he insists on talking. They actually just talk a lot. That's not like a reproductive talk, but actually they just talk. That's like a gramping of words going on, and they just talk, right? So they have flight of ideas. You can say that type of energy in themselves at that moment actually made their thoughts to be racing. All right. So at that very particular moment, they have a lot of ideas going on. All right. They have distractibility. That is the attention will be easily drawn toward an in irrelevant, insensitive stimulus. All right. They would be talking like from one topic to another, then just going on, right? That's like they aren't able enough to stick on one topic and talk about it. That's just distractibility from one topic to another, right? So, increase in the goal-directed activity, that is either they are working at some kind of place, or at school, or um, in any kind of behavior, like even in the sexual activities, all right. They have a very much increased need to do that particular task, all right. Or the psychomotor agitation, that is the purposeless, non-goal directed activities. They just been working like that work does not even belong to them, but they just keep doing that because of their huge pile of energy going on, all right. Or a client is having an excessive involvement in the activity that have a very much high potential for the pain consequence. Those kind of persons actually have you can say a very much orientation toward the foolish business investments, all right. At that particular moment, they actually don't care about the painful experiences, or you can say the outcome of that particular behavior, all right. Those kind of people love to do stunts, all right. That's a different profession, but yes, they love that. They even love to experience new kind of activity, all right. They are not even well trained in that. So yes, All right. So these were the particular symptoms we talked about that was regarding the mood disturbance period for like the 1 week. All right. And at that particular moment, along with the increase of energy or the desire of certain activities, from those particular symptoms, if any of these three or more are present, then you should be very well aware that something noticeable is going on, right? So, if the mood disturbance is significantly severe to cause any kind of impairment in their social, occupational, daily life, all right, their personal life, then yes. Or you can say at that particular moment, if you think that particular patient needs to be hospitalized now to prevent their harm toward their self or toward their other people around themselves, then yes, right? Then you must consider it towards the manic episode. All right. If the episode, but you have to be sure about it that this particular kind of episode is not attributable toward any physiological effect of any kind of substance. That can be a drug, that can be, the medication side effects, that can be the side effect of any other treatment they had gone through. All right. So you have to be very well aware to rule that thing out first. All right. So, till this point, we have discussed what actually manic episodes are. All right. So, you have to understand that in case of manic episode during an antidepressant treatment, for example, an electroconvulsive therapy, for example, some kind of medicational therapy, it happens. Yes. But if it's a fully syndromal level, or you can say it has a very much huge physiological effect, then yes, we have to consider for treatment of that particular episode first, right? Okay. Till now, we have discussed about the criteria for the manic episode, right? But you have to understand, along with these four criterias, at least one lifetime manic episode is required for diagnosing the bipolar 1 disorder, right? In case if a patient didn't have any one lifetime, the experience for the manic episode, then you have to be going through another phase of the disorder, right? We will talk about it later. Okay. So we have discussed about the manic episode. Now we'll be going towards the hypomanic episode. What is hypomanic episode? It's basically almost the same as like the manic episode. But you have to understand about the duration difference about it. In case of mania, we have understood that S episode would remain for at least a week. All right. But in case of hypomanic episode, that kind of irritable mood with the elevated mood, or you can say an abnormal mood going on, the abnormality should last for at least 4 consecutive days. All right. Not about at least a week. It's about less than that, right? But at least the 4 consecutive days. All right. Along with the irritable mood, along with you can say elevated mood or abnormal something going on with their mood, a patient having an increase or persistently, the desired activity or energy, then you have to be very well aware to go towards the time duration of the disorder. All right. You would have to consider what's the problem going on first, then you have to consider about the duration of the problem. All right. If it's about a week, then it would be manic episode. If it's about less than a week, and you can say it's about the 4 consecutive days, then yes, it's going to be hypomanic episode. Otherwise, all the details would remain the same. It's not about very much different in that. All right. In case if all the first two criterias have been met very clearly, the episode is not is very well associated with an unequivocal change in the function. That is actually an uncharacteristic for an individual when not symptomatic, right? Or I can say a particular change that had happened during the episode is actually not very much a characteristic for that particular person when he is not having that particular episode, or when he was not having any kind of symptom going. All right, there is something different now. So that particular that particular change in the functioning is needed to be addressed now. All right. In case of hypomanic episode, you can say the disturbance or the change is very much observable by the others. All right. But that doesn't require that kind of extent to be observable that you think a patient needs to be hospitalized. In case of mania, the problem is going to that particular peak that the surrounding people would perceive that particular person threat to himself or towards the others, and that's why they would suggest to be hospitalized. But in case of hypomania, it's not like that. It's something going on, like all the other symptoms, but patient would be having the very new symptomology right now, a very much changed person right now. In that particular episode, have the kind of consistent change going on in that particular person when he was not having any kind of symptom. Yes, but the change is observable, but to not that particular extent that anyone would suggest hospitalization. All right, it's not so severe enough to cause a very remarkable impairment in the social, or the occupational or the workplace environment in that particular person. All right. So yes, that's the difference between the manic episode and hypomanic episode. All right. And that would remain the same. So as we have discussed previously, in case of manic episode, a patient having at least one lifetime condition of the manic episode previously would have a diagnosis of the bipolar 1 if having a depressive episode right now. But if a patient doesn't have any history of the manic episode clearly, but right now hypomanic episodes are very common in the bipolar disorder, but are not required for the diagnosis of the bipolar disorder. Let me be very clear. If a patient having a manic or hypomanic episode right now with a history of manic episode, he would be considered for the bipolar disorder 1, right? But you have to be very well aware of the history first of all right? So now we are talking about the diagnostic criteria for the major depressive disorders. As we have talked about, there would be in case of diagnosis for the bipolar 1 disorder, you have to be very well aware that in case of bipolar 1 disorder, as we have mentioned lately, all right, at least one manic episode must be present in the lifetime history of the person. All right. Okay. So it's been clearly mentioned here. And in case of bipolar 2, it's actually necessary to have at least one currently or in the previous history, one hypomanic episode along with the major depressive disorder to be diagnosed with the bipolar 2 disorder. All right. So previously we have discussed about the major depressive disorders in a very huge detail. We have a lecture about it. So we won't be going through a lot about it. We would just read about the symptomologies. All right. So the basic criteria, diagnostic criteria for the major depressive episode is that the particular symptoms, at least 5 of them must be present for at least 2 weeks, all right, to represent some kind of a change from the previous functions or the pre-morbid personality of that particular person, all right. The first thing is to know about the major depressive episode is the depressed mood. And the second thing is loss of interest, or the tyrant, any kind of activity. All right. So these are the two particular key components to remember that either of them can be present in case of major depressive disorder. All right. So for first of all, if the client doesn't have any other attributable cause, and you are talking about particularly about the psychological disturbances. So, he's having a depressed mood for like every day, nearly every day, and it's been reported for like for the past 2 weeks. All right. And sometimes their subjective reporting would be like, I'm feeling sad, I'm feeling like hopeless, I'm feeling like empty inside. It's like I'm lifeless. I doesn't know if I'm alive. All right. These are the particular statements you would listen from the patient. All right. By the observation of the others, um, people would be like, he is actually being childish right now. He actually behaved like a child. He would cry a lot. He is just emotionally being broke down. It's like that, right? He's having an irritable mood most of the time. He stays depressed. He stays cut off from the environment. He doesn't like any social gatherings now. So these are the depressed moods, all right? And if they are actually arguing about markedly diminished interest or the players, all right, in their most of the day or daily functioning, so we would be considerate about that. Okay. Sometimes when we are talking about the physiological symptoms for the depression, you would notify about significant weight loss or very much gain, all right? Sometimes people gain weight in case of depression. All right. So the change in this appetite would be very significant. All right. Or insomnia or hypersomnia. Sometimes people just love to sleep in case of uh, a depression because they just have you can say they just don't like social gatherings. They just don't like any kind of social interaction at that moment. So they just fell apart and they just stays lay down. All right. So then psychomotor agitation or retardation, you can say they just lay down all the time in their room, like lights off, curtains down, each and everything must be, the indicator for being dark. So at that moment, if it's like that, then it's psychomotor retardation. If a person is having very much agitation, then it's another continuum for the depression. So they report a fatigue or loss of energy like nearly every day or most of the time. As we have discussed previously, it's about the worthlessness, hopelessness, fatigue, all right, inappropriate guilt. It's about that. In case of depression, always remember in a very extreme kind of major depressive episode, person can express certain kind of delusions, all right? And that's sometimes about the inappropriate guilt about the past, all right? So then their activity or their ability to actually think or concentrate sometimes get retarded. All right. They are just being not able enough to make some kind of decisions. All right. They just doesn't like to actually communicate. So that's the reason their ability for making decisions appropriately, to concentrate on any kind of task, to express their thinking patterns very well are being blurred. All right. So they can have a very much recurrent thoughts of that. Okay, societal ideations are very much present in case of depression. So these are the particular continents for the depressive episodes we have talked about. All right. Now we would come toward our basic topic, that is the bipolar 1 disorder. As we have discussed previously, in case of bipolar 1 disorder, at least one manic episode throughout the life should be present previously. All right, or the current episode should be manic episode at least. All right, and having a very much indicator with a major depressive episode. Okay, so along with these two episodes going on, or you can say these two combinations, these are not better explained by any other kind of disorder like the schizophrenia, schizoaffective disorder, schizophrenia form, any kind of delusional disorder, or any other kind of psychotic disorders going on. All right. You have to make sure to rule out them first. All right. So after you have discussed about it, after you have um, acknowledged about the episode, if a patient, I'm repeatedly suggesting this statement because students get confused about it a lot when they have to diagnose bipolar 1 and bipolar 2. In case of bipolar 1, a manic episode with a major depressive episode should be present. All right. They should have a history of manic episode first. Okay. Then it would be major depressive disorder. In case of bipolar 2 disorder, at least one or the current episode should be hypomanic episode along with the major depressive episode in the history of current episode. Okay. Then it would be bipolar 2 disorder. So now we would be talking about the bipolar 1 disorder. We have talked about the criteria. We have talked about their um, uh, differentials. Now we would be talking about their coding and the recording procedure for the bipolar 1 disorder. First of all, you have to make sure what is the current or most recent episode, its status, all right, if it's active episode or not, if it's anxious distress, or what is the current feature along with the severity index, all right. Then the presence of the psychotic features with if a remission status is present, you have to be sure about it and you have to mention along with the diagnosis. All right. So current severity or the psychotic features are only indicated if the full criteria are clearly met for the manic episode or the major depressive episode. Sometimes there are a lot of patients which have a very much clear cut presentation for the bipolar 1 disorder. So at that moment, you realize that the current severity and the psychotic features are clearly ruled out. All right. Their remission specifiers are only being indicated in case if their full criteria are not currently met for any kind of disorder. All right. Their remission specifiers will be used. All right. So these are the particular specifiers you have to be very well aware about when discussing about the bipolar disorders. The first one is with anxious distress, then mixed features, then rapid cycling, then melancholic features, atypical episodes, and then mood congruent psychotic features, then incongruent, catatonia, peripartum, seasonal. These are the specifiers. We will talk about these specifiers lately, but you have to make sure about you have to write down when diagnosing the patient with any bipolar disorder. So now moving forward toward the diagnosis for the bipolar 2 disorder, you have to be sure about the DSM-5 criteria. That would be for diagnosing the bipolar 2, as we have discussed previously, as we have revised previously. Your current or the past episode for at least one time should be hypomanic episode. All right. Then following the current criteria for the major depressive episode, at least, right? So, um, at least one manic episode with at least one major depressive episode would be bipolar 2 disorder. In case of bipolar 1 disorder, at least one manic episode along with one major depressive episode will be bipolar 1 disorder. So, in case of bipolar 2 disorder, patient has never been having manic episode previously. All right. Then the occurrence of the hypomanic episodes or the major depressive episodes are not explained by any other kind of psychological disturbance. All right. You have to make sure about the differentials alongside. All right. So the symptoms of the depressions are, the unpredictably caused by frequent alternations between the periods of the depression or the hypomanic episodes. Clinically have a very much significant distress or impairment in the client's social and occupational daily living function, workplace environments. All right. So these are the codings for the bipolar disorder. All right. We have discussed about the coding previously. as like a bipolar 1, you have to make sure about the writing the diagnostic code for the bipolar 2 disorder. Then you have to make sure that what is the current severity status. Then you have to make sure to write down the presence of the psychotic features. All right, the course, and obviously the other specifiers cannot be coded because it should be indicating in the writing. Like it's been here as an example. This as the targeted code for the DSM in case of bipolar 2 disorder. All right. So whenever you are writing about the bipolar 2 disorder, you have to remember this is the only code you have to write it down. Bipolar 2 disorder, then current episode is depressed, then moderate severity. What is the severity has been mentioned here with features. What is the feature? It can be like anxious distress, it can be mixed features, it can be mood congruent psychotic features. So these would be mentioned here. All right. But you have to make sure to write the current episode as well. It's being here mentioned here. All right. You have to make sure to write if the current episode is hypomanic or depressed. You have to write it down there. Okay, in case of your diagnosis. So if the course of the full criteria are not met, either in case of bipolar 1 or in case of bipolar 2, you have to write it down. Okay. So um it's partial remission or it's full remission, you have to carry it like that. In case of specifiers severity is completely met, all right, in case of any of the mood episode, then you have to make sure to write the severity as per the uh, graph of the DSM-5. All right. So here comes what's a cyclothymic disorder. All right. Today we would discuss about these disorders, and then alongside that, in the next class, we will be talking about their uh, remaining things that would be the treatment management, their psychopharmacology, and all that stuff because um, it's 2 days lecture on this topic that is the bipolar disorders. So time is running out, so let's just clear it out first. What is cyclothymic disorder? Sometimes when you would be in practice, you would notice that patient is between the swing, or you can say a patient is not actually having a complete presentation for either depression or the hypomania. So patient would be in the phase that moment. In the hypomanic phase, the person would appear, kind of like high, but not so high to be socially or professionally incapacitated or, you know, needs to be hospitalized. And in case of depressed phase, the patient symptoms of depression are present, but not so severe to meet the criteria of the full major depressive episode. So in that moment, you can see the individual with the cyclothymic disorder tends to like having a swing from a high to low, or maybe chronic mild mood instability. So I can say for like patient have very much numerous episodes of the hypomania from the last 2 years, but um, they do not actually met a full-fledged criteria for the hypomanic episode or have a very much numerous depressive symptoms, but they actually do not met a full-fledged criteria for the depression, right? So in that moment, you have to realize that it's not clearly about the bipolar 2 disorder. It's about cyclothymic disorder, where the symptoms are not prevalently met the whole criteria for the disorder. All right. About those two particular episodes, right? So during the above two periods, if the hypomanic and the depressive episodes have been present for at least like half of the month, and the patient has not have been without the episode for like 2 or more than 2 months, so you have to consider to look forward to that. All right. The full-fledged criteria for any of the three episodes, like the depressive episode, manic episode, or the hypomanic episode, had never been met from the last 2 years. All right. But the symptoms are present from time to time for like being absent from like less than 3 months, right? So in that particular time, you would be suggesting toward the cyclothymic disorder. Okay. Symptoms should be differentiated from other psychological disorders, that is schizoaffective disorders, schizophrenia, schizophreniform, or delusional disorders, right? They are not physiologically attributable to any other kind of picture, like substance abuse or any kind of medication or any other medical condition like hypothyroid, right? So in case of substance-induced bipolar-related disorder, when we are talking about substance-related induced bipolar disorder, it actually means that this particular persistent or prominent disturbance in the mood have been basically the clinical picture of, you can say, any kind of use of drug, all right, or any other kind of substance, all right. There is an evidence from the history or a physical exam should be present to suggest that the symptom of the first criteria, that is the persistently elevated or disturbed mood, and the second thing, that is the remarkably diminished interest or depressive mood, is present just because of exposure to that particular medication or the substance. All right. Second, that a particular substance should be capable enough to produce symptoms in that particular person. All right. You have to make sure to study that substance first to say that this particular substance or medical induced bipolar disorder is present. All right. Then those particular substances are not better explained by any other disturbances or the psychological factors. All right. Such evidences of independent bipolar related disorders could include the following things. You have to understand that. That is, you have to proceed about the onset of the medication or the substance. You have to study about the symptoms relevant to that particular substantial use of that particular substance. All right. You have to make sure about the effects of the severe intoxication of that substance. All right. So these are the particular things you have to study when you are talking about the substance or medication induced bipolar disorder. So the substance or the medication induced disorder should not have occur exclusively during the course of delirium. In case of delirium, if a client is having a neurocognitive or neurodegenerative disorder, you have to make sure to rule out that first. All right. In case of other specifiers or um, um, bipolar or related disorder or unspecified disorders, that is basically about the short duration hypomanic episode. That is 2 to 3 days, all right, with the major depressive disorder. All right. The hypomanic symptoms, if not sufficient to present symptoms and the major depressive episodes in the lifetime history of a person, then you would be suggesting about the other specified bipolar disorder if the presentation of the particular disorder is clinically significant to cause distress or impairment in the person, but do not meet the full-fledged criteria for any other disorders, or right, then in that case you would be suggesting about um, you can say the reassessment after a certain period of time, right? So today that will be the whole class about the disorders. We will be talking about the